Opportunity to ask questions about anything that's been confusing thus far. Because again, this is kind of a review. Any things from previous lectures, from the small group cases that you want to ask about? It's all been crystal clear. So, and Dr. Curry is here. Excellent. I have to ask him to do something. So this is, I want this to be interactive, and we're going to have some small prizes as soon as Dr. Curry returns. So please speak up. Okay? There's no prizes available yet. But yes.
I would be interested in knowing how to look at an X-ray in more of a systematic way. So when you get an X-ray, like what to look at.
Yeah, we have some X-rays. Yeah. Unfortunately, I just have one X-ray, but we'll do that today.
Piggyback off that, like particularly to me, like it's pretty difficult to like tell the difference between like a reticular appearance of like intralobular thickening and bronchial thickening.
Yeah. No, that's the third X-ray question I've just had. So we'll practice it more in the small groups too. But really learning to interpret X-rays is a skill for third year. We are not going to ask you on the exam to come up with a diagnosis just based on an X-ray. In some of the stems for the questions, we include X-ray descriptions, but there will be other information that leads you, to an answer. So, again, next Friday, please try to come, because the exam, one complaint that we have, which I think is good for you, but it's still a complaint that I've heard, is that they've not seen an exam exactly like ours, because we've tried to write it like your step exams and your board exam. So there'll be a stem, 48-year-old man comes in with these symptoms, has this X-ray, and you need to kind of figure out what's going on. And then if you don't figure out what's going on, you're not going to be able to answer the question. Okay? So it's sort of a two-step logic to get to the answer. So we'll practice that in the review session. And so part of that stem is going to be X-ray findings, but there's other information that'll be there too. So I don't think you're not going to really have to be X-ray experts to answer any exam questions. But I will show you some X-rays today. Other questions? Okay. So this is actually a patient that I recently saw in clinic and that I was struggling with. So it's going to be a little bit harder, but I think with your collective minds, hopefully we can come up with an answer. So this is a 56-year-old man. He has a history of asthma and gastroesophageal reflux disease, who was referred to us for worsening asthma. He was pretty stable until 2 years ago. He had asthma, as I mentioned, was on daily Advair, which is a combination of fluticasone and salmeterol. So it's a combination inhaler. He was only using albuterol once every 8 months or so. So pretty good asthma control. Hopefully you learned how we judge asthma control from yesterday's lecture. Prior to 2 years ago, he had really no limitations. He jogged 60 minutes on a treadmill, weightlifted, was playing tennis, very active guy, fit guy. But then 2 years ago, his cough started to worsen. Started to use more albuterol to treat the cough, was given an empiric course of steroids, and at that time felt better. Okay, but then about a year ago, cough worsened more, and then he became more short of breath. And his exercise tolerance really decreased dramatically. He was now able to only walk for 20 minutes, and at that point was exhausted. He was given a trial of Augmentin, an antibiotic. It's a penicillin antibiotic, and didn't really improve at all. At this point, he was using albuterol when he came home from work. Again, not getting much relief from it. Got a second course of steroids. This time it really wasn't helpful. And then right before we saw him, got a third course of systemic steroids without much benefit. So, right, as all good history takers, you want to go through your pertinent positives and negatives. So besides the cough and dyspnea, he was wheezing, and this occurred with his usual asthma triggers, which was cold air and dust. His cough was intermittently productive of brown sputum, and he was producing sputum daily. He also had occasional mild night sweats, and he had these days of just feeling lousy. So his symptoms weren't consistent necessarily every day. He'd have these days where he's really fatigued, achy, with no energy. Then he'd have a better day where he was able to do more activities. Otherwise, didn't have any fevers, chills, weight loss, chest pain, palpitations, orthopnea, P&D, lower extremity edema. Questions? So when he came to us, he had these spirometries done, and they date back to 2012. And this is his first spirometry. Okay, who wants to take a shot at that? So FEV1, 71% predicted, FVC, 87% predicted, and a ratio of 65. What's the first thing you look at in spirometry? Effort. Good. And I'm not showing you the effort, so let's just assume that the effort is good. Okay? Then the next thing you look at, the ratio, is this. I haven't given you the predicted, but remember, for this aged man, it's probably going to be 75 to 80%. So is this ratio up, down, or it's down? So you're thinking, I heard two different answers. Say it again. Obstructive, right. So this is obstruction. And as Dr. Horowitz reiterated, how do we grade the severity of obstruction? And just the FEV1% predicted. Does anyone remember from Monday's lecture what 71% of predicted, what category that would put you in? It's mild, right. So he's mildly obstructed. Okay? And then, just a few months later, this is his pulmonary function. Ratio is still down. And now what's the severity? It's moderate now, right? His FEV1 has gone down to 63%. He's got very poor flows at mid and low lung volumes. And what is this telling you here? He's hyperinflated and he's, someone said it, air trapping, right? Okay, and all that's consistent with what? Obstructive lung disease, exactly. Okay. And his GLCO is normal, which will help us in the differential diagnosis. Then he has a few other studies that are all pretty much similar to this October of 2012 study. Okay? All right, just to fill in the rest of his history, I told you about the asthma, the reflux. He's on a sulfa medication. These are the medications he's taking. He's using albuterol, not just by meter dose inhaler, but he has a nebulized machine where he can take the albuterol. This is what he's been using when he comes home from work. And what's albuterol again? The short-acting beta agonist. Okay. He's on the fluticasone salmeterol, which again is an inhaled steroid and long-acting beta agonist. He's on montelukast or Singulair, which is a leukotriene receptor blocker. So what are all these treatments really for? Asthma, yeah, although Dr. Horowitz just mentioned that we use this for COPD treatment as well as albuterol. He's also taking omeprazole, which is a proton pump inhibitor for his reflux disease. And then I told you he'd been receiving these prednisone burst and taper. Prednisone is a steroid glucocorticoid that you take by mouth. Okay? Social history, never smoker, but his wife smokes, drinks a glass of wine per week, has a dog at home. Family history, has asthma in a brother and a daughter, cancer in his mother. Any questions about any of that? Any other information you want? Okay, so this was his exam. Blood pressure, systolic a little bit high, but otherwise his vitals were pretty normal. Weight was 220 pounds, BMI 32. Otherwise, his exam was pretty unremarkable except for his lung exam, where he had diffuse wheezing, but good air movement, no rhonchi or rales, wasn't tachypnic, no increased work of breathing. So what's your differential diagnosis at this point? Common things being common? Bronchitis? Like what kind of bronchitis? Chronic bronchitis? Okay. Okay, just worsening asthma. Excellent. Good. So those are the most common obstructive diseases. Have you learned about any other obstructive diseases this week? Say it louder.
Bronchiectasis?
Yeah, and bronchiectasis. Good. So those would be the most common things. So what favors asthma in this case? He's got a history of asthma, right? What else? Yeah, so he's got obstruction on his PFTs. Are there things that make you think this isn't asthma? Yeah, he's not responding to the typical treatments anymore. We can see that happen. Patients can become more resistant to standard treatment, but boy, after a steroid burst and taper, you'd like to see some improvement, right? And with bronchodilators, usually asthmatics are going to feel some benefit from those, and he's not. So that's really pushing us away from asthma. What about COPD? What's missing for COPD? He's not a smoker, right? So that makes chronic bronchitis and emphysema a little bit less. Why also do we think he doesn't have emphysema? What good data do we have? Normal DLCO. Excellent. And then what about bronchiectasis? Do we have anything favoring that? Do you know how those patients present? Think about the CF patient that you learned about. How do they come in? I mean, they're usually diagnosed in childhood, or at birth, but they have chronic cough, right? And what about their cough? It's productive, and what do they produce? Sputum. And what's the sputum like? What? Thick? Thick? Yeah, and what else? Is it clear, colored? Purulent, yeah. So it usually looks green, yellow, brown. So this person had this cough producing brown sputum daily. So that's kind of consistent with bronchiectasis, right? Good. So I just kind of filled in a table here. He's got this prior history. He's wheezing with triggers. It's a common disorder. But really, purulent sputum production is not part of asthma. Poor response to albuterol and steroids. COPD is also common. He does have some secondhand exposure, but is that really enough to drive this? Probably not. As Dr. Horowitz was talking about, usually these patients have 20-pack year histories. He has a normal DLCO, so emphysema is unlikely. Here he has purulent sputum, but he didn't respond to the antibiotic. So does that make bronchiectasis less likely? Maybe, yeah. Okay. So what else? What information do you want to have now to help you get at what the diagnosis is? Someone said, say it louder. Chest X-ray, imaging, yeah. Good. And we also obtained our own pulmonary function tests. So those are here. So this, again, was just earlier this year. Pretty similar to what he was showing. So the ratio is reduced. He's got moderate obstruction. Very poor airflow at mid and low lung volumes. Okay? So here's his x-ray. Since we wanted to take some time interpreting the x-ray, who wants to throw out what they're seeing?
Right diaphragm's really elevated.
Okay.
And then on the lateral view, there's quite a bit more opacity near the hilar region in the apex.
Here?
Yeah, the apex.
Okay. So he's pointing out that the diaphragm is elevated here. You can see that here. And then he's a little bit worried about the hilum. Any other comments? So how do you go through x-rays in a systematic way? Okay. Did Dr. Pernicano talk about that at all? Not really. Okay. We kind of use this A, B, C, D, E, F, G approach. So we'll fortunately, it doesn't go much beyond G. First thing we often look at is the airway. Is the airway midline here? Okay. And you can look at the spinous processes behind. And here's his trachea. You can see it come down. Here's the left main stem, right main stem. And you think the trachea is midline? Or it's a little bit deviated to what side? The right side. Okay. Excellent. Next, we look at the bones. It's hard to see the bones in fine detail on a chest x-ray. So if you're worried about a fracture, it can be challenging, especially a rib fracture. Sometimes we'll do more dedicated rib films. But what I use the bones for is just to kind of get a gestalt about what the volumes are in the lungs. What is the sweep of the chest here? And normally, Bob Green was a pulmonologist here, was just fantastic at teaching x-rays. Normally, it should sort of look like someone's pulling your chest up with a hook here. It's this nice upward sweep, okay? And do you see some asymmetry here between the right and the left? Yeah, what side looks smaller? What side? The right, exactly. You don't get this nice, apex being pulled up here and then coming down. Okay, so we've seen the airway being pulled this way. There's less, kind of a less volume here, I guess I'll say. Sometimes you can see that the rib spaces are closer together too, to decide if the volumes are equal on each side. So that's the B, that's the bones. Then C is looking at the cardiac silhouette. You're trying to decide, is it normal size? Is there any thing that's silhouetting the cardiac borders here? Any comments on the cardiac? Yeah, it looks pretty normal. I think that's what Dr. Curry said. Yeah, you can see a nice left heart border. You can see the right heart border. Size is okay. All right. D is the diaphragms. The first thing that popped to your mind was this diaphragm is up. Good. Dr. Green always used to say, you have to decide, is the diaphragm up on this side, or is it down on the other side, or some combination of the two? And we'll come back to that point in a second. E is looking for effusion, so look at the costophrenic angle here. Is it blunted? Is there a meniscus sign here? That can be a sign that there's pleural fluid. Okay? So E, F. Look at the fissures. Okay. Is there anything else for F? Okay. So you can try to see the fissures are usually not visible on the PA film except for the minor fissure. You can see a fine line. Maybe we're seeing it there. Okay. And then the major fissure runs diagonally. You can often see it better on the lateral. Yeah. Yeah, there you can see it. Yes. So the minor fissure, the major and the minor fissure on the lateral actually defines the middle lobe. So the middle lobe sits anteriorly here, and it usually is right over the heart shadow. Okay, so sometimes when you have a opacity in the middle lobe, it can be hard to appreciate because you're also seeing the density of the heart, but it should silhouette the right heart border here. Okay, whereas if you have a left heart border silhouetted, that will be a lingular opacity. If the diaphragms are silhouetted, that tells us there's lower lobe opacities. Okay, so the silhouette sign can be very useful to tell you where the abnormality is in the lungs. I guess the other thing I use F for is the lung fields, which is what most of us jump to quickly. So you're trying to decide, is there any opacification here? Is there any increase in his interstitial markings? I'm going to ask the senior pulmonologist because that's a hard thing to do. Do you see anything that looks abnormal in his lung fields? Here? Yeah, there's something a little funky here. Okay, so lung fields, fissures, F, G, that kind of alerts me to look at the gastric bubble and look below the diaphragms. What we're often looking for is free air under the diaphragms here. H, look at the hilum of the lung. Does that seem enlarged? I agree, whoever said this looks a little bit prominent, but when you look at the PA film, it looks pretty normal to me, so I'm not going to make much of that. All right. I is instruments. Do we see any lines here? And I think it pretty much stops at I. So I don't see, he doesn't have any lines in, any intravenous catheters or endotracheal tube. So the most prominent abnormalities are the trachea is pulled over, there's an abnormal sweep of the ribs, and the diaphragm is up here. So what does that all tell you? All right, so he's got some volume loss in the right lung, and that could be from atelectasis. Good. It could be that he's had some prior lung resection. I mean, it could be that this diaphragm is weak. I mean, when it comes up, it often will squash the lung a little bit, and you'll get atelectasis.
And on the lateral view about the wispiness at the top.
Up here? Yeah, a lot of these, you see a lot of overlapping lines here because, again, you're going to get a tracheal shadow, esophageal shadow, some clavicle or scapular shadows. So, yeah, there's not much I'd make. This is a really hard area to look at on a lateral film. So,
How can you tell if there's a right heavy diaphragm elevation, whether it's the lung pulling up versus the liver pushing up?
Yeah. Excellent question. I mean, this really seems to be that there's volume loss using these other clues, that the trachea is over, again, the sweep of the ribs. It doesn't seem like this lung is, for some reason, hyperinflated. If this lung was really black and this looked more normal, that might tell you that there's something, pushing things over. But
diaphragm is clearly elevated here, but one thing that might give you this, what I would call a deep sulfur sign, is going down very low here, is pneumothorax. But if you wanted to combine a pneumothorax with volume loss to the right, you have to say that this side is full of air, like potential pneumothorax. that would obviously argue against that. If it's deep fissure, you might need a pneumothorax. But again, that's not a statement. You have other signs suggesting that there's probably somewhere over here. You can't see kind of a deep fissure like that.
You guys, have you heard the phrase red herring? Yeah. So all of this is kind of a red herring for what's going on. I don't really know why his diaphragm is up. Okay. But it's actually a very nice film to actually start practicing your observation skills on. So not very helpful. At least we didn't think it was helpful, unless we have the diagnosis wrong. But
what's atelectasis?
Atelectasis is basically lung parenchyma that's collapsed. Okay? Often you'll see it as sort of a band-like opacity. So what do you want now? What would help you to figure out what's going on? Think about our differential diagnosis. We've got, of those three things that we had on the list, what is everybody favoring? Bronchiectasis. How do you diagnose that? Get a CT scan, right? Good. So we got a CT scan, and you haven't seen many CT scans, so I won't belabor you trying to interpret this. I just picked out a few cuts that show you some abnormalities. Does anyone see the abnormalities, just really quickly, in the lung parenchyma? Yeah? Yeah. You want to point them out?
Okay, do
Take
it.
control.
Yeah.
Take.
They've only had half the coffee. So
Half a cup.
try it first time.
Oh, just push the top one and don't shine it in my eyes. Okay. So you're looking for bronchiectasis, right? You went right to the airways, looking at their size. Yeah, those are probably, especially that one that you pointed to second, is probably a little enlarged. What do you see right above that? Yeah.
Also this.
That's abnormal too. And go to the top one. You see? Yeah, that's good. Yeah. So we call those ground glass opacities. You can kind of see through them. So he's got these little small patches of ground glass. What does this look like to you? If you can be really imaginative. What does this look like? You got to be really imaginative. Think about. Well, let me show you the next. And there's more of this kind of stuff here, right? There's just, and again, you'll have to a little bit take our words for it because you haven't seen a lot of CTs. But a lot, and this stuff was scattered throughout. And then down here, again, we're looking for airway dilatation. And there are some airways, it's pretty subtle. I probably wouldn't have called this, but the airway walls are thick. You can really see the airway walls pretty prominently here. I don't see that they're tremendously enlarged. But we call this, or the radiologist calls this tree and bud opacity, because it sort of looks like the end of a tree branch, when the buds are swollen. Okay? And again, I know that's very hard to imagine. Again, more sort of tree and bud stuff than some minor airway enlargement. So this is what our radiologist said. Patchy areas of ground glass attenuation in the left upper lobe, which we saw. Then this tree and bud nodularity that's scattered throughout. And said findings are compatible with an infectious process. A prior reading on another CT scan they were a little bit maybe more adventurous and called the presence of bronchiectasis. I certainly wouldn't call it moderate, but I think there's probably mild evidence of bronchiectasis.
Would you ever get a sputum culture, or would that just take too long?
Excellent question, and yes, you would, but you're getting ahead of me a little bit. So, all right, so this supports which of our diagnoses? Yeah, bronchiectasis. Although it's not rip-roaring, I think it's still pushing us down that path.
Is it usually patchy like that, or are you going to see it on almost all the slices?
Depends on the severity, yeah. And that sort of leads me into my next slide. So bronchiectasis can be focal. It can just be in one lobe. That usually is because you've got airway obstruction. The middle lobe often can be abnormal and not drain, and you can get recurrent infections there. If someone aspirated something at some point in their life that never got cleared, that lobe beyond that can develop bronchiectasis. If you had a bad pneumonia in one lobe, that can cause bronchiectasis. But what we're seeing here is more diffuse disease, okay? And so you need to come up with a differential for diffuse bronchiectasis, okay? And bronchiectasis kind of shares this common vicious cycle of pathogenesis where you have abnormal mucus clearance, you get infection, inflammation, airway damage, and then this just keeps going. The airways get larger and larger. And what do you know that causes bronchiectasis? CF? Okay, good. What else? Is that the only thing? So an infection? Yeah, a bad childhood pneumonia can do it. What else? Tuberculosis can do it, and other mycobacterial infections. Okay. What else helps to protect our airways? What are our innate defense mechanisms? Yeah, so ciliary abnormalities. You can inherit defects in the ciliary apparatus, and those patients will get bronchiectasis. So primary ciliary dyskinesia, cystic fibrosis. How else do we protect our airways? Do we have anything that helps us fight infections? The immune response, good. And we have immunoglobulins, particularly IgA. So immune defects. What we most commonly see here are immunoglobulin deficiencies, IgA or combined variable immunodeficiency, which is usually an IgG subclass plus IgA. There's a disorder that is associated with asthma called allergic bronchopulmonary aspergillosis. Dr. Horowitz had it on his differential. This tends to give you central bronchiectasis, and it's an allergic response to aspergillus that's colonizing the airway. These patients uniformly have asthma, so in this case, this would be something that we'd probably put fairly high on the differential. We can actually see bronchiectasis with other autoimmune disorders like rheumatoid arthritis, ulcerative colitis. And then, as you guys said, post-infection, including mycobacteria, a bad pneumonia, pertussis, measles, these things can lead to bronchiectasis. Okay, so what do we do now? Do we want to do a culture? Good. And we also want to try to start ruling some of these things out, okay, to see what the cause is. Oh, chronic aspiration. So if you take an adult with diffuse bronchiectasis and you do all of the workup to try to figure out why they have it, still about half the time we don't really know why, okay? So there's a lot of this pathogenesis that we don't understand. All right, so he came to us with an IgE. An IgE is kind of a screening study for ABPA. Patients with ABPA typically have IgEs over 1,000. So this kind of made that diagnosis a little less likely. And there's your sputum culture, okay? He's growing Haemophilus and Pseudomonas. Now, are these the causes of the bronchiectasis, or are these secondary to the bronchiectasis? These are secondary, right? These are not the infections that drive the process. But once you have bronchiectasis, you are set up particularly to culture Pseudomonas. For whatever reason, Pseudomonas loves the bronchiectatic airway. All right, so we sent off a bunch of other studies to try to figure out what was going on here. We repeated the IgE and a specific IgE to Aspergillus to look for ABPA. We obtained a sweat chloride to look for cystic fibrosis. We did quantitative immunoglobulins to see if he had an immunoglobulin deficiency. and pretty unhelpful. So the IgE, again, was only 123. The specific Aspergillus, IgE was a little bit elevated. And again, he has asthma. So maybe ABPA here. Sweat chloride was very low. The immunoglobulin levels were all normal. Okay? So what now? Help?
Kind of PPI,
He was on a PPI.
Having GERD and then aspirating cause this?
It's a thought. Most of the time when people chronically aspirate to cause bronchiectasis, there's usually some defect in their swallowing mechanism. They've had some kind of neurologic insult, a stroke, or excellent question. So what we typically do is a nasal scraping, and we look at the cilia under electron microscopy. So we could do that. We haven't done that yet here. He has children, which makes the diagnosis a little bit less likely, but some patients with immotal cilia syndromes can still have children. So the fellow in the clinic who was taking care of this patient kind of thought this was ABPA. The treatment for ABPA is steroids, and then we often will give an antifungal agent. So he wanted to give, this is just to show you kind of the things that we've ruled out. He had no history of this. We didn't think he was chronically aspirating. We ruled out immunoglobulin deficiency, CF, so this is still on the differential. We did get a culture here for the young man who wants a culture. And again, we saw pretty typical, so let me just go back. So when I say infection here, these are the bacteria that are causing that infection, that are driving this process. But again, they come secondarily. So because of these cultures, we tried a course of levofloxacin, which actually has good coverage of Pseudomonas. It's an oral antibiotic. And the sputum cleared up. It was no longer brown, but his dyspnea got worse. And he now had dyspnea simply with walking. He also continued to cough at night. Albuterol was very limitedly effective. No fevers, chills, chest pain, palpitations. Okay. Again, the fellow thought he had ABPA, so gave him another course of prednisone. And we wanted to get PFTs after that. Again, he felt no better with the steroids. Breathing continued to decline. Has to catch his breath more often. So that treatment failure was sort of pointing us away from ABPA. And the serologies really weren't that impressive. Okay? We got another set of PFTs, and now his FEV1 is down to 52% of predicted. Again, he continues to have air trapping, pretty normal DLCO. All right, so he's getting worse despite antibiotics orally, prednisone. So then what would you do? What's that? You want to get a biopsy? Okay. What do we want to biopsy?
So you're giving like oral steroids. Try and inhale steroids with that.
He's already on inhaled steroids. Yeah, he's on the Advair. What else could you get? I thought you were going to...
Inhaled antibiotic.
You can give inhaled antibiotics, but those are usually more for maintenance treatment. Anthony, you don't know this case, do you? Okay, so that's reasonable to try to figure out what's going on. How would you treat him at this point? Okay, yeah. So he wants to give him IV antibiotics, bring him in the hospital and give him IV antibiotics, really treat the Pseudomonas well. So, good. I'm glad. I think like the great Dr. Corey here. We did it as an outpatient. We put a PICC line in. We gave him IV antibiotics. Cefepime is a broad-spectrum cephalosporin, which covers Pseudomonas. We gave him a second anti-pseudomonal and oral ciprofloxacin and treated him for a couple weeks. No improvement. And then he said he was coughing up some really dark stuff from down deep, which was very concerning to him. So now, Dr. Curry wants to do a bronch to get better specimens, which is not, we were definitely considering that. We still haven't ruled out ciliary dyskinesia. There's one other thing, just really go back quickly. What else have we not ruled out on this as a cause of? This is something that Dr. Horowitz knows the case, so I can't ask him. We don't think he has TB, right? He's living in southeastern Michigan. But there are atypical mycobacteria that don't come up in regular cultures. So this young man who wanted cultures, you're on the right track. But we have to do that with a specific culture. And we really hadn't sent that yet. And he still was producing sputum, so a diagnostic laboratory test was ordered. And what did that show? What's that? Nothing useful. But it was a diagnostic study, though. So it had to be. A lot of times we do operate in the dark, yeah. Well, so we really hadn't sent one from a sputum. So we just got a sputum. Usually mycobacteria are acid-fast positive. You probably learned that in ID. His smear was negative for acid-fast bacilli, but ultimately he ended up growing Mycobacterium avium complex, okay, which is a relative of tuberculosis. Again, we commonly see it in this scenario where patients have bronchiectasis, chronic symptoms, and if we don't treat it, they don't get better. It's more commonly, classically seen in older women, particularly older thin women. We call it Lady Windermere syndrome. You can look up why it's called Lady Windermere syndrome. But this guy wasn't a lady. He wasn't particularly thin, and maybe that's why it wasn't really on the forefront of our diagnoses. But by the time he hadn't responded to any of our treatment, we thought this was probably the case. So what do you want to do now?
Just a quick question. Along those lines, do you see this in like toxo and histo as well?
So those are fungal infections. And then those can be chronic, but oftentimes are more acute infections. And they don't typically give you bronchiectasis. They will give you more cavitary pneumonias, often with an upper lobe predominance.
Is there any way that we could try to indicate whether or not the mycobacterium is like only growing there because of bronchiectasis or it's causing it? Because
Give that guy a prize. That's an awesome question. Yeah, because it's a chip. Should we take it away because he can't catch, though? Yeah, it's a chicken or the egg story, right? Because when patients have bronchiectasis, this bug, similar to Pseudomonas, likes to come in. But in this case, we found no other etiology, so we think it's probably the cause. So for another prize, who knows the treatment for atypical mycobacterium? Azithro and rifampin and usually ethambutol, okay? So not too different from TB. Maybe a couple other, is that all you have left?
Well, yeah. It took like 5 minutes to get one out of the damn machine. You guys can all split these. I'm not. I'm not the quarterback. Of course, he sucks too. So,
So really, in very short order, he felt yes, yeah. In short order, he felt almost back to baseline. Was jogging 4 to 5 miles, playing tennis, and look at what happened to his pulmonary function test. FEV 197. Yeah. Occasionally we help somebody in pulmonary.
It's rare. But
no, stop saying that. That's not true.
I actually,
I need to get your thing now.
yeah.
The FEF 25 to 75 values.
Yes, we do. Well, what is the FEF 25? So that's forced expiratory flows. So what is that describing? Yeah, and it's being derived from the flow volume loop. So in essence, that is telling you that you have coving without looking at the flow volume loop. Right. But most of us have, that's a very sensitive measure. So you don't, and that's why I always tell you, look at the FEV1 to FVC ratio first and make sure that's down, and then look at the FEV1 to grade severity. To me, that's really telling you, is this more small airways disease versus upper airway disease? Patients who truly have obstructive lung disease have FEF 25/75s almost always, severely reduced, like 40% or less. And it would be rare to have FEF 25/75 less than 40% and not also have a reduction in your FEV1. So,
Would it just be normal if you're restricted?
it's typically normal, yeah. Yeah.
We're just not able to get the microbacteria in the sputum culture.
Yeah, you need to send a special culture, and that had not been sent from his previous evaluation at the outside hospital, and we did not send it. When we first sent his sputum, for some reason that wasn't sent. Yeah.
sometimes it can take 6 weeks.
Yeah, and it takes 6 weeks to grow, so we often have to wait for it to come back. All right.
Before it comes back, would you ever treat that prophylactically or at that point?
Yeah, the antibiotics are hard to take, so no. Yeah, so this guy's on treatment for a year. So you really have to commit to it. So we will treat tuberculosis empirically, but that often can present more classically than this. This is often a subtle presentation. So, all right. Dr. Corey is going to take over. I'm actually going to another meeting. So thank you, guys. We'll see you in the small groups. And
Can I have that copy, by the way? Or no?
yeah, I can print. I'm
having issues. Thank you.
You want both of them?
Yes, please. Okay, so we'll go kind of more quickly just because Tom really took a lot of time to go over kind of the intricacies. Oh, no, I didn't mean it that way. I meant that he will have primed you for much of kind of the conundrums. He's faster, but I'm bigger and stronger. All right. So anyhow, just to let you know that this case is kind of so that you don't think that everything in pulmonary that's obstruction is either asthma, COPD, or bronchiectasis, because that's far from the truth. So this is a 52-year-old woman in my clinic who presented to me from somewhere in Michigan, wherever, with shortness of breath and some wheezing, and she had a history of asthma that in the past she basically said, she'd take albuterol on a very intermittent basis, and that was for years, and whoop-de-doo. And then she started getting several years of kind of progressive worsening shortness of breath with exertion, and she had seen all of her doctors and 4 pulmonologists and what have you, and been basically treated for asthma over and 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 over again, and then also was treated with antibiotics just because, hey, why not? This is a common scenario in the community. Patient comes in, give them an antibiotic. So hopefully you will be more thinkers given the excellent training that you received. So this was the scenario, kind of, is this really asthma? Gee, sure doesn't sound like it, sort of a thing. So I'll tell you that her past medical history was, in fact, notable for this asthma that she very well described. Also wanted to point out, Tom said that productive cough is not really a part of asthma presentation, and it isn't in a chronic sense, unless it becomes complicated, as this case may have been, his case may have been. But remember that asthmatics get colds, they get snot, they cough it up, right? And so don't just think because somebody has an acutely productive cough that they may not have asthma, all right? I just wanted to make that clear. She also had a history of rheumatoid arthritis. She was on Advair, which is the inhaled corticosteroid fluticasone plus the long-acting beta-agonist salmeterol, and albuterol. The HFA just stands for the device high-frequency actuation. And then methotrexate was given once weekly with folic acid, which is a common treatment for the articular joint manifestations of rheumatoid arthritis. Family history, mom had rheumatoid arthritis and died of COPD. Interestingly, the patient even noted that although she died at a fairly young age, I believe 60, that she was never a smoker, nor did she live with a heavy smoker or what have you. Sister was also asthmatic, and father was kind of not in the picture, obviously. And she reported the review of systems that was most notable besides her respiratory complaints of shortness of breath on exertion. She didn't have a productive cough, but with this morning stiffness. Her vital signs were pretty unimpressive. The most impressive thing about her was I think she was manic from all the steroids that she had been on. She was quite interesting. Remember, the steroids are not benign. I mean, I have patients that literally go berserk when I put them on steroids, and they're complicated, and sometimes I need to put them on, and I just know they're just going to be like wearing 27 different colors and pressured speech when they come in, and these are not benign agents. On exam, she had kind of large lungs to percussion. I think I remember telling some of you in the hospital visits that the number one reason to examine your patient is actually not that we get tremendous diagnostic information all the time, but patients are very impressed when you examine them. Most doctors barely examine their patients, if you want me to tell you the truth, and I'm kind of a truth kind of a guy. So when you examine your patients, it may be more for the patient and establishing an effective relationship with the patient than it may be that you're actually thinking, gee, do they have the finding of Kukutsamugi disease or whatever sort of a thing. But patients are very impressed, and you need patients to listen to you because if they don't, you're ineffective. All right. So she didn't really have any additional sounds except with forced expiration. She was very prolonged and had maybe a very faint wheeze in the bases. But overall, the most predominant finding was that her breath sounds were just really decreased. And then, of course, she had some kind of ulnar deviation and a little bit of MCP inflammation, no rheumatoid nodules. All right. So because she had been seen over and over and over again, I got a chest x-ray on her. And we don't all use the ABCDE, but we all do something that is systematic. And if you want to be a good doctor, you have to learn to be systematic. Okay, that's just the bottom line. And so for me, the first thing that I do is always check the name, which I have obviously cut off here for HIPAA purposes, but it will be up here. And then you basically want to check the technique. Does anybody know if this is a PA or an AP film, and if so, why? Normally you can say it's a PA if I cheat and give you the lateral, but which one is this? For treat. This is so pathetic. I mean, you're like doctors and I'm offering you candy. But anyhow, I'm sorry? Speak up. It's the front. What do you mean by the front? So it's either the PA or the AP. Do we know what those letters stand for? Anterior and posterior, and that's whether the film is in the front, where the beam is from the posterior to the anterior, PA, or in the back, AP. And the reason you know that this is a somebody, who said it? PA? Oh, I suck. I'm sorry. Edit, bleep, bleep. So we know it's a PA for the principal reason that the scapulae are actually externally rotated. And if you know about how we do this, we have the patient either sit or stand and put their arms up on handlebars. And this causes the external rotation of the scapulae out of the lung fields, and that's the principal reason for doing this. The other advantage is that we don't get projection artifact of the mediastinum, which is a big problem in AP films and people who are either barrel-chested or obese, right? We can get a lot of confusion about the kind of the big heart, so to speak. So this is, in fact, a PA. In terms of technique, again, the number one thing when you're looking at studies is to say, is this a quality study? Because if it isn't, throw it away. Don't look at it. You don't want to misinterpret or misdirect a patient because you got bad information. It happens all the time, okay? So this is a good study. It shows that the patient has a midline trachea. The clavicular heads are kind of what we use. What I'm going to show you is, if I think of the tips of the clavicular heads, here and here, the vertebral-thoracic spines, if you find directly on, will look like that. They'll be an equal distance, okay? If I'm kind of left anterior oblique, where the left clavicle is much in front, you'll notice that the pen has not moved, but it appears to have moved relative. And so it will appear much closer to the thoracic spine, okay? And conversely, right anterior oblique, okay? So normal, rotated, rotated. I didn't move the pen, at least not on purpose, okay? So that's something you need to look for. The other thing you need to look for, okay, so the other thing, the clavicular heads are pretty good. Here's the edge of one, here's the edge of another, the spines. That's pretty good. The other one is we want to know the depth of inspiration. Thank you very much. Which should be 8 to 10 ribs. And this is a little bit tricky, so bear with me. This is the first rib anteriorly, and it arches over under the clavicle there. This is the second rib, and it goes right there. So this is the third posterior, fourth posterior, fifth, sixth, 7th, 8th, 9th, 10th, and we're at a floating rib. We're at 11. So what that suggests to us is what? Is she just super strong? Just kind of... She's probably hyperinflated, all right? And that's probably not surprising to you since she's an asthmatic, she has hyperinflated lungs. I told you decreased breath sounds and some wheezes. All of those would fit this finding. And then she has a thin cardiomediastinal silhouette. The pleura are not thickened. Does anybody know what these dots are? They're radio-opaque nipple markers, actually, because a lot of times nipples will actually look like nodules, and the patient will get a CT, which we don't want them to get, so that's an important thing. The costophrenic angles are normal, okay, maybe slightly more pronounced on this side. Breast shadows, obviously. Ribs are very hard to read, but I didn't see any gross rib abnormalities. This right here is the right lower lobe pulmonary artery. It's always a little bit prominent. You just have to accept that. A lot of doctors misinterpret that. And then looking at the lung fields, the general thing that stands out to me is that they appear to be a little bit overlucent, a little bit too black, and just big. I don't see anything obvious. And chest x-rays are like EKGs relative to echoes, right? Very crude. I mean, let's face it, this is what they had, and that's what they did. But a CT scan kicks the pants off of this, all right? All right. So we have hyperinflation, and this is a CT scan, and I just gave you one cut because you haven't studied these. I can tell you that 99% of doctors, period, do not know how to read a chest CT scan or an HRCT scan, so don't feel bad about that. When I see you in the ICU, I'll give you a lecture on it, and it'll all be fine. The bottom line is it's actually much easier to read a chest CT than it is to read a chest X-ray, in my not-so-humble opinion, okay? Because it's not really a game of shadows anymore, okay? It's actually an anatomic thing that you can look at and know. Again, Tom pointed out a little bit of these hazy nodules and what have you, and you see a little bit of this here, right here, this tree and bud. What I wanted to point out is that tree and bud actually means you have a bronchiolar disease, okay? You could argue maybe a vascular disease, but more than likely you have a bronchiolar disease, like a bronchiolitis. You could have a chemical bronchiolitis, an infectious bronchiolitis, an inflammatory bronchiolitis, any number of causes. So this lady appears to have bronchiolitis, okay? Inflammation of small bronchi. So here's Uncle Tom's favorite study, PFTs. These are also not hard to read. I just want to point out that I put the FVC in the order that we get them here at the U, which is the FVC comes first. So you're first going to look at the ratio. I think you can agree in a 52-year-old that 47% is grossly abnormal. And then you'd want to do what again to look at the severity? FEV1, it's 38%. So this is in the severe to very severe range, okay? And then she improves a little bit with a bronchodilator after inhaled albuterol, not technically meeting our criteria, but she, 12% and 200 cc's, but she did improve a little bit. And then I'm going to give you her TLC was kind of upper normal. And I didn't put her RV to TLC, but you would already know that her residual volume was high. And how would you know that based on looking at this set of pulmonary functions that I gave you? Don't forget to complete your algorithm, right? So I put this up here on purpose. We looked at this number, it was low, so we said obstruction, duh. So then we said, oh, this number is really bad, very impressive, she has severe obstruction. And I tried to see if I could trick you into not looking at her FVC, which is low, okay? So remember, the FVC can be low for two big reasons. You can have true restriction, you could have a low TLC with that, or your residual volume could be very, very high. And in this case, this is a reflection of a very high residual volume, and you see that with the TLC. And her RV to TLC ratio was very elevated at 189% of predicted. So again, supporting that this is very severe obstruction with air trapping, okay? Importantly, not a very good bronchodilator response, and I already knew that clinically, right? She told me she'd been treated with this inhaler, this combination, a bunch of prednisone, antibiotics over and over and over again, and she really didn't get better. All right, so thoughts. In summary, you had a 52-year-old woman with asthma and rheumatoid arthritis who presented with kind of insidious worsening, progressive shortness of breath. She didn't respond to treatments for asthma, including very aggressive treatments. She had severe obstruction without good response to bronchodilators, and she had evidence of air trapping as marked by the low FVC with a high TLC. Thoughts?
And I don't know for certain, but can rheumatoid arthritis cause a type of COPD?
It can cause a type of obstructive lung disease. Very good. Yes, excellent. So the type that it can cause is actually what she has. It's called, most people would call it bronchiolitis obliterans. Bronchiolitis obliterans is kind of a constrictive bronchiolitis. I don't like the term bronchiolitis obliterans, and I'm going to actually go on a little ditty here, use my soapbox to create a new generation of doctors who doesn't use stupid lung terminology. When I give you the ILD lecture, you're going to want to hate me, and you're probably going to love and want to hate the pathologist. But don't blame us for these really stupid terms, but we have really dumb terms that we need to get rid of in pulmonary. So we use the term bronchiolitis obliterans, organizing pneumonia, and organizing pneumonia like all over the place, and they just confuse the heck out of you. So I'm going to make that confusion go away. These people develop a constrictive bronchiolitis. What that is, if you think about kind of atherosclerosis, it isn't atherosclerosis, but it's intimal scarring, subintimal fibrosis of the small airways. And basically, they just get choked off. And they present as insidious shortness of breath typically, although it can be acute. We'll talk about that. And they don't respond to bronchodilators. They don't respond to much, actually. Other causes for constrictive bronchiolitis. So this is what she had. Excellent. I think you've earned the remaining candy for that. Or you can share it with your colleagues, since you already have one. So a little bit about constrictive bronchiolitis or bronchiolitis obliterans. It can be caused by inhalational injuries like chlorine gas exposures. It can be caused by severe infections, most classically childhood viral infections, adenovirus, these sorts of things. It can be caused by medications. It can be caused in the setting of complications of certain other diseases. Classically, chronic lung transplant rejection is a constrictive bronchiolitis, okay? Graft versus host disease of the lungs in a bone marrow transplant, allopathic bone marrow transplant patient, is constrictive bronchiolitis. And the other big group that we see besides medication-induced is rheumatoid arthritis. I think nationwide this is probably the most common, but people miss the diagnosis all the time. The key here is when you talk about bronchiolitis, there's two big kinds, okay? There's constrictive bronchiolitis, where you have air trapping, severe airways obstruction, insidious shortness of breath. The chest X-ray is big and black. The chest CT is big and black, all right? And that's constrictive bronchiolitis, okay? Kind of fibrosing and choking off of those bronchi. There's another bronchiolitis that we call, and just feel free to laugh out loud, bronchiolitis obliterans organizing pneumonia, because that's clear, or BOOP, or COP if you want to get the new cute, sexy, horrible name. But what it really is a proliferative bronchiolitis, not constrictive. It's a proliferation of connective tissue within the bronchial tubes. It usually presents as a pneumonia that doesn't go away, okay? The chest x-ray has either white nodules or white splotches or what looks like a big consolidation, okay? And they may have restriction on PFTs, okay? So a very different setup, should have a different name. And when you give those people steroids or take away the cause, they get better very quickly. So-called melts away in just a matter of a few days. It can come back very quickly if you don't taper the steroids off. So constrictive bronchiolitis, big, black, obstructed, versus proliferative bronchiolitis, BOOP, COP, can be an injury, result of an injury from many kinds, medications, infections, many things, or just idiopathic, goes away with steroids and often shows up with restriction. Okay, so very different things, much easier to remember than these silly overlapping terminologies. All right, very good. So that's all I wanted you to know, is to have my little diatribe on constrictive bronchiolitis. Were there any questions of confusion about any of the lectures that came up to this point? Question in the back?
You talked about the tree and bud. Is that a presentation of constricted airways?
It actually can be, yes. If you looked at where those little trees and bud, where the little bud part would end up, it would be in the middle of what we call the secondary pulmonary lobule. And that's where the terminal airway, the terminal bronchiole, and the terminal pulmonary artery actually live. Okay, and that's why I said chest CTs are actually easier to read and learn, because you can learn an anatomic correlate and come up with a disease differential diagnosis based upon that. Very good question. Any other questions about this case or any others?
How do you treat this case?
So in this case, we usually treat the rheumatoid arthritis more aggressively. It could be any number of biologic modifiers, etanercept, rituximab, all sorts of things. The truth of the matter is these patients usually don't get better, and lung transplantation is often somewhere in their future. So she's kind of smoldering along. She does have some asthma, and so we kind of have to always decide, is this your asthma, or is this just worsening of your underlying constrictive bronchiolitis? Notice I use the term constrictive bronchiolitis. And hopefully she'll get many years out of this before she needs a lung transplant. Okay? Say again?
When you give supplemental oxygen.
So supplemental oxygen, that's a great question for two reasons. I'm going to take advantage of your question. We give supplemental oxygen to people whose oxygen saturations are below 88%, either at rest or with exertion. Okay? And we do that based upon some studies in COPD, which we don't even know extrapolate very well. I will tell you that the number one reason for patients with severe obstructive lung disease to feel short of breath has absolutely nothing to do with having low oxygen. Shocker. Okay? It actually doesn't. And they don't feel better when they wear oxygen, and they don't like to wear oxygen, by and large. It's a big social stigma to walk around with a stupid tank and tube, and they really hate it. The number one reason why patients with obstructive lung disease are short of breath is air trapping, what we call dynamic hyperinflation. As you know, these patients have an air exit problem. Air goes in fine. A lot of times their lungs are very compliant. They expand very quickly. And if you saw my slides that you were supposed to get, you'd see that slide about FRC and emphysema patients who actually have a very high resting lung volume, and they breathe very few super big breaths. The reason is so that they have a very long time to exhale with each breath. And when they don't, i.e. with exercise, okay, that air gets trapped. And the analogy I'll use, and you'll have to imagine that I have a massive bicep here. Some dude in the back did, but actually I don't. So this is my bicep. So if you imagine that a bicep is your diaphragms, when you exercise and you air trap more, you end up kind of doing this. What does your bicep do in this position for all of you future orthopods? It opens a door. It doesn't do squat. It does a little bit of external rotation, future orthopod. No? Maybe? Yeah. Anyhow, very boring. Anyhow, good patient outcomes, lots of money, mechanics, whatever. So that's what it does. And then when they stop breathing, because they have to stop doing what they're doing, they just can't breathe anymore. If you want to learn what this feels like, take a deep breath in. Don't exhale. Take another breath in. Don't exhale. Take another breath in. If you feel like crap and lightheaded, you're now experiencing the life of this lady when she tries to walk, or somebody with severe emphysema. So it really sucks. All right? What they have to do is stop. They may also do this. You may see them doing pursed lip breathing. The reason is, if you try and breathe in very quickly, let's have a race. Since you're having a running commentary, which I'm enjoying, by the way, with your big brown eyes, I want you to just start breathing fast and deep as hard as you can. Ready? And I'm just going to do pursed lip breathing as fast as I can. The point is, I'm an athlete. You may not know it. But the bottom line is this. The bottom line is, I can't do it fast. Nobody can do pursed lip breathing fast. Okay? That makes them slow down. That improves their air trapping. And if they do it before they exercise, they can actually do better. Thank you for participating in the game. Another question. Any questions?
Was the mother's history of COPD, was that likely actually COPD? Or
No,
something
of course
related?
not. She probably had the same thing. In fact, this sister has just been referred to me 3 months ago, and the concern is this is actually a familial rheumatoid arthritis-associated bronchiolitis problem. Good question. You guys are smart.
But does it help at all to like be upside down?
To be upside down. It might, in the sense that when you need to force expiration, you use your rectus, and a lot of patients who are short of breath are not fit, okay? So they may not have a good rectus. So being prone might actually help to generate more pressure for expiration. These patients don't typically sleep in that position, so it's probably not a big thing, but it's possible. Now, any other questions about this case or others?
Not about this case.
Sure.
Do you mind going over the intrathoracic large airway obstruction and the extra?
Yes. Yes. So when I took my medicine boards, I believe it was, back in the, I don't know, Pleistocene era, whatever, the first thing I did when I got my paper was I drew out these little pictures that I'm going to suggest that you... What is that? Oh, I'm going to do it for everybody. Okay. So... So this is inspiration, and expiration. Oops. Is this. Do we agree? When we inspire, we increase the volume of our chest, okay, and the intrathoracic airways are pulled open by radial traction, okay? So if there's an intrathoracic obstruction, we're not likely to see it pronounced in that setting. However, the extrathoracic airway, your throat, okay, think of the morbidly obese person or somebody with super big tonsils or something, that's going to get sucked together. That extrathoracic airway is going to get closer together. So in inspiration, you're more likely to see an extrathoracic obstruction, and that will give you... Whoops, I said inspiration, didn't I? Squared off here in exhalation. This is inspiration. Exhalation. Okay? As opposed to this patient who has intrathoracic obstruction, we're going to see that during exhalation. So that's this. Does that make sense?
I get the graphs, but I still don't get why one happens. Yeah, I don't know.
Okay, so say that I have a 5 millimeter nodule in a 10 millimeter airway on the right here, okay? Or let's say I have it in the trachea, okay? So I have a 50% reduction when I'm not breathing, okay? When I breathe in, that trachea is going to get larger. The relative narrowing of that 5 millimeter lesion, say my trachea with inspiration is now 15 millimeters. I went from a 50% reduction to only a 33% reduction. Do you think you'll see that in PFTs in that maneuver? Or when I exhale, that trachea is going to get smaller to 7 millimeters, and now I have a 5 millimeter mass in a 7 millimeter airway. Will you see airflow obstruction in a 2 millimeter airway? So when I exhale, that trachea is going to get smaller, right? Now that 5 millimeters is about 80% of the airway diameter. Does that make sense? Okay, so that's why we see intra and extrathoracic obstructions in these more prominently. It's not that they are or aren't there, although some people are dynamic. Okay, so that's what I do. I draw these pictures. As soon as I get the test, I draw those pictures. It just helps you. All right, any other questions about any lecture to this point? Any concepts? Nothing. Your small group sessions are probably the best learning you'll ever have in your lives if you've put in the work to it. These are difficult concepts. A lot of doctors don't know this. If you know everything in those small group sessions, forget the stupid test. 99.5% of you pass the stupid test. If you know what's in those small group sessions and the concepts, you know what you need to know about pulmonary medicine as just a regular practicing physician. That's just straight up truth. So put in the time, put in the effort, pay attention, please interact, otherwise we just talk all day long at you, which is really boring. But they're really well done, okay? So you'll get a lot out of those. Thanks for coming, and hopefully it was helpful. This airways obstruction.